cardiovascular system together. And so that's what I'm going to be going over. If you have any questions, of course, put them in the chat, and we will cover those. And if you have a question, I mean, I don't mind you unmuting and asking kind of in the moment if that's what you are comfortable with, or you can write it down and ask at the end. So whichever you prefer.
Devin, are you okay to do the screen sharing again for us?
Sure, let me get it pulled up.
Thank you.
Oh, I have a joke. Let me tell the joke. I've gotten some new material this semester, so that's been exciting for this group. What is a kidnapper's favorite shoes? Kidnapper's favorite shoes. White Vans.
Oh my God. That goes really well with we had our sexual assault thing yesterday. Did you go to that online?
I did.
Yeah. Perfect.
That was my my reasoning for looking for something with that sort of content and nature. So I found it. I think that's a good one. Share it with your friends. All right, so respiratory system we're going to start with. And our first slide is going to be about cystic fibrosis. And I'm going to do a little bit of a review on some of these slides because I'm not quite sure how in-depth you got during the program, but just for us to have information in case we need to answer questions regarding it. So we'll refresh a little bit about cystic fibrosis. It's an autosomal recessive trait. Now, what does this mean? It means that there's 2 copies of a gene that must be present in order for the disease or the trait to be present. And in the case of cystic fibrosis, you get an exocrine gland dysfunction that usually results in an abnormal mucus secretion or an obstruction. So an exocrine gland, let's define that real quick, is a gland in our body that's present that makes sweat, tears, saliva, digestive juices, and is released from a duct with a T or an opening. And when you have a small passageway that gets thick or tenacious mucus buildup, you can start to kind of really imagine how it's not so good for your patient, because that's what a patient with cystic fibrosis has, is a tenacious mucus buildup. And so this abnormal mucus secretion can become an obstruction. And you can see from this illustration that it can often occur in the lungs and the digestive system. And cystic fibrosis is generally progressive, it's incurable, and often leads to the bottom line of this illustration that results in death, most commonly from respiratory failure. Next slide. So I couldn't find a picture of cystic fibrosis, so I put my steak dinner from last night up. I mean, it kind of looks just about the same. I'm sorry, that was another bad joke. This is a cystic fibrotic lung. And these patients can often have emphysema along with cystic fibrosis and an atelectasis, which leads to severe narrowing or obstruction of the airways. Generally, we're going to hear abnormal lung sounds such as wheezing, and increased risk of recurring pneumonia and even respiratory infections with these patients. They're also going to have chronic hypoxemia, which can often lead to a pulmonary hypertension. And for patients with chronic sort of lung diseases, including cystic fibrosis, we can even, as nurses, assess clubbing of the fingernails. They're going to have low pulse oximeter readings. They're going to have a cough, some shortness of breath, and fatigue. Now, in the gastrointestinal sort of section, they can have an ileus or an obstruction that can occur. So what we could see commonly in those areas is abdominal pain, some distension, nausea, and vomiting. Deficiency in important vitamins and electrolytes these patients will have, including A, D, E, K. They're generally going to have high sodium and chloride levels, and these patients can often be anemic as well. They're going to bleed and bruise easily. Cystic fibrosis patients are often at risk for dehydration and other imbalances. High sodium, which they already have because of the disease process, is scary because that can lead to brain swelling. And they can have abnormal potassium, which can lead to cardiac arrhythmias. These patients are often also malnourished, and we throw around the term failure to thrive with malnourishment. So if you hear failure to thrive, that is related to malnourishment. For patients that are younger in the adolescent phase, puberty can be delayed, and there can also be fertility issues like sterility. The goal for a cystic fibrosis patient is to prevent and treat pulmonary infection, since we saw in that last slide that they can often have respiratory failure. So that's what we want to focus our treatment and management on, is improving their aeration and trying to thin or remove as many secretions as possible. So some interventions that we provide are CPT. We're going to give meds like enzymes and bronchodilators. We're going to focus on mucus clearance. We want to thin the secretion, so hydration is really important. And because they're at risk for malnutrition, we want to monitor their weight and provide good quality nutrition for them. And we want to monitor their electrolytes. Next slide. Now, completely unrelated to cystic fibrosis, we have our first question. The pediatric nurse is instructed to monitor a child diagnosed with epiglottitis. The nurse notes that the child is leaning forward with the chin thrust out. The nurse interprets this finding as indicating which condition? Okay, so you guys chose 100% of you, and 100% of you are correct. That is a beautiful response rate from you guys. So to be able to answer this question, you have to be able to break down epiglottitis and kind of understand what that means. The epiglottis is a flap structure at the top of the larynx, and itis is inflammation. And so you add that together, you can potentially have respiratory distress in this patient. And so the patient's body position indicates that they're trying to achieve optimal oxygenation, really highlighting the fact that they have a difficulty breathing. So good job with number 3, you guys. Okay, the nurse is assisting in the care of a child returning from surgery following a tonsillectomy. The nurse should place the child in which position on return from the operating room? Okay, so the answer is going to be number 2. So 21% of you got it. I can see why you guys would choose high Fowler's, but let's break it down here for a second. Tonsillectomy is the removal of tonsils. And one of the things that we want to monitor for is postoperative bleeding that can occur in the back of the throat. And so the sideline position is actually going to help facilitate drainage from coming out of the mouth, as opposed to the patient sitting up and slightly back. They could be just swallowing that blood. And so when we monitor for signs of bleeding, we actually want to watch for frequent swallowing, but the sideline position facilitates the drainage out as opposed to them swallowing it inward. A client is admitted to the emergency department after being thrown from a motor vehicle. The nurse suspects the presence, excuse me, of a closed pneumothorax, if which finding is noted during data collection. Okay, there's a pretty good mix here. I like it. So a pneumothorax is an accumulation of air in the pleural space, and that actually impacts the natural negative intrapleural pressure that we have in our lungs, and that causes a collapse. Generally, what we're going to see primarily in a pneumothorax is a shortness of breath and chest pain. The patients are going to complain that they really can't catch their breath. And certainly they have shallow breathing because of this chest pain from the actual collapsed lung. We're also going to notice upon assessment, as the nurse, is decreased breath sounds to that affected side. So if it's the left lung, we would have diminished or even absent breath sounds. Really paying attention to the fact that the patient has a pneumothorax is important, because if you listen to the left side, you might be hearing some lung sounds from the right side. So going in with that patient, knowing that they have a pneumo, you can anticipate diminished or absent breath sounds on that affected side. You're also going to see a unilateral chest expansion. So if the left side's collapsed, you're going to see more of a movement on the right. Dyspnea, shortness of breath, sharp chest pain, changes in their vital signs. They're most likely going to have hypotension, increased heart rate, increased respiratory rate, and they're going to have some potential tracheal deviation. Okay, so how do we work to correct a pneumothorax? We use a chest tube. In some circumstances. So I mentioned before that our lungs function under negative pressure, and a chest tube is needed to restore that negative pressure to the intrapleural space. And so a chest tube can remove air or fluid. It can do either one. There is usually a drainage collection chamber, a water seal chamber that collects air, and the air actually escapes into the water, and the water doesn't allow it to re-enter into the pleural space. And there's also a suction chamber, and we're able to calibrate and control the negative pressure of the chest based on this little calibration meter that comes on the chest tube. Our role as the nurse for caring for patients with a chest tube is to maintain the patency of the tube. The dressing needs to be maintained sterile. If we need to change it, it needs to remain intact. So we don't want it to be loose around any edges, because that could potentially cause some air to leak into the chest tube entry site. And we need to make sure that we're having drainage from the pleural space into the chest tube collection area. And we need to make sure that we're looking at our orders. We can't do any chest tube management without a provider's orders. So we want to do continual assessment of our lung sounds, their work of breathing, their oxygenation status, and their pain. Patients with chest tubes say it's very painful, and they often have short, shallow breathing, and that doesn't really help them to exercise or expand their lungs. So we want to do appropriate pain management so that we can then encourage turn, cough, deep breathe, and send a spirometry. At the bedside, just in case we have an unanticipated or even anticipated removal of the chest tube, we need to make sure there's clamps at the bedside. Usually sterile gauze and an occlusive dressing should be kept nearby. Next slide. The nurse volunteering in a homeless shelter is providing information about risk factors and signs of tuberculosis. The nurse instructs the clients that which symptom is the earliest one associated with TB. Okay, so the majority of you chose 4, which is the correct answer. So a couple of things that really are going to help you to understand, we're going to talk about tuberculosis on the next couple slides, is identifying the risk factors for tuberculosis. And so in this question, we see that we're volunteering at a homeless shelter, and we want to talk to patients about risk factors or signs of TB. So a homeless shelter itself, or a crowded area, long-term care facility, prisons, those actually are put our patients at an increased risk for developing tuberculosis. In addition to age is also a risk factor. I mean, you guys have probably heard that the entire program, the very young and the very old are at risk. Drinking unpasteurized milk is also a risk factor. Homelessness or lower socioeconomic statuses or groups put you at higher risk for developing TB. In addition to being around frequent contact of someone with TB. So that's going to put you at higher risk as well. And so if we go back to the question, we see homeless shelter is going to be a risk factor that we want to pull out here. Intermittent chest pain, that could be more associated with a cough and not something that would really go along with tuberculosis. A bloody productive cough, that might be associated from increased cough or increased irritation of the lining in the throat from a cough, shortness of breath or dyspnea upon exertion and at rest. That's not really associated with it, but a morning cough producing mucoid sputum is one of the earliest signs associated with TB amongst looking at your client's potential risk factors. The nurse who is assisting in admitting a client who is tentatively diagnosed with TB expects to note a prescription in the client's chart for which diagnostic test that will confirm this diagnosis. Okay, so there's a pretty good mix here of answers. Let's go through each one and figure out which one's the correct one. So chest x-ray is pretty popular, and for those of you that usually get a chest x-ray associated with the TB test, because you're always positive with your skin TB test or whatever, a chest x-ray is actually not definitive. It may show findings that suggest tuberculosis, but may also get confused with something else. So it's definitely not definitive. It's part of like a whole diagnostic picture, if you will. Number 4, tuberculin skin test. We're all very probably familiar with this, but this doesn't necessarily mean that you have the active TB disease, but rather an exposure. So those two are not the answer. The answer is actually number 3, a sputum culture. This is going to be the best measure of the presence of TB and will confirm a diagnosis because it's actually coming from the patient and they can do laboratory diagnostics to determine if the tuberculosis is present in the sputum. So the answer was 3. All right. So here is a picture of lung tuberculosis and what the actual bacteria looks like on the left-hand side. TB is a multi-drug resistant disease that's transmitted through inhalation of droplets from a person with active tuberculosis. The tricky part about TB droplets is that they're very small and they can suspend in air for a long time. Which is why when we're caring for patients, we have to protect ourselves so we don't have prolonged exposure to the patient with TB, and we need to protect ourselves by wearing those fancy N95 masks that, to be an appropriate N95 mask, have to be appropriately fit to your face, and you have to have fit testing done to make sure that there's a good seal. That way you're protecting your airway. And so if you're caring for a patient with TB, your prolonged exposure is minimized because you're protecting yourself. Nick, you have a question? Go for it.
Yeah. So why would they have you take an X-ray if it's not definitive?
For you who always has like a positive TB skin test, or a patient that they're suspecting has TB?
Okay, gotcha. Thank you.
Yeah, so it's going to be, they might do a chest x-ray for like this whole diagnostic picture. Okay, so let's do a chest x-ray because, I mean, it's kind of invasive, but not really. We're exposing them to radiation, but let's see what their lungs look like. They have a positive TB skin test. Okay, they have some changes on the x-ray. Let's get a sputum culture. So they might do multiple things just depending upon the patient. For you, as someone who may always have a positive skin test reaction, they might do it just to ensure that you have no lung changes seen on the x-ray, which is probably why they would choose to do it. But if you had a history of tuberculosis, they might do a multi-layered sort of thing to get a full picture. Okay, cool. Oh, go back real quick for me, Devin. Sorry, I wasn't done. I talk a lot. It was spring break, and like, you know, I sat around and meditated and prayed and just was quiet. And so now I have to talk a lot to catch up. So persons with TB can be asymptomatic, or they can have very vague symptoms that can look like a lot of other things: malaise, fever, cough, weight loss, anorexia, and lymphadenopathy, which is your enlarged lymph nodes. And so assessment and your history taking, figuring out what risk factors your patient has there been exposure, is going to be crucial to be able to make that appropriate diagnosis. So you'll have that TB skin test, you'll have the chest x-ray, and you'll have that sputum culture. And once you have a diagnosis, medication therapy is used to hopefully decrease the risk of a latent infection becoming an active one. Okay, now you can change the slide. A client with tuberculosis is being started on anti-tuberculosis therapy with isoniazid. Before giving the client the first dose, a nurse ensures that which baseline study has been completed. Okay, we have a good majority. Liver enzymes is the correct answer, number 2. Isoniazid is an antibiotic, and it's going to be used to treat the tuberculosis infection. But some of the things we need to know about this particular med is that it can be hepatotoxic and have hepatotoxic effects that can cause, your patient can become jaundiced. And so you want to really get a good baseline of liver enzymes before they're started on this therapy. Next slide. The nurse reinforcing health maintenance strategies for the client with COPD, chronic obstructive pulmonary disease, would include which item? Okay, nice. Yearly influenza immunizations is correct. Number 4, you got it. That was really good, you guys. In this question, note health maintenance. And so that's really what can the client do for themselves to protect themselves. And so if they have COPD, they have a chronic disease that increases their risk for infection. And so getting a yearly influenza immunization would help mitigate them getting super sick. Fluid restriction we don't do with this sort of client, not cystic fibrosis, heart failure, kidney dysfunction, we would do fluid restrictions. COPD doesn't really increase your risk for a tuberculin skin positive result. And we definitely don't want to limit physical activity. If you remember from level 1, mobility is extremely important. And so number 3 would be out as well. So you got your number 4. Next slide. I like this illustration. It's a really good one. It gives you kind of everything you need to know about COPD for your patient. COPD is really an overarching theme for any disease that can be characterized by an airflow obstruction of the lungs, including bronchitis, where you have inflamed bronchioles with excess mucus, emphysema, where the air sacs are damaged or enlarged. Primary features of COPD include an onset after the age of 40. Some healthcare providers might throw asthma into a COPD sort of disease process, but it's actually not when you look at what the primary features of the disease are. So onset of after 40, generally we don't see asthma starting that late in life. With COPD, you're going to have abnormal lung function. During asthma exacerbations, you're going to have abnormal lung function that will return to baseline or semi-normal with medication therapy. Heavy exposure to risk factors for COPD, smoking, occupational pollution, and it's progressive over time. You're going to have long-term hyperinflation, and you're going to see chest x-ray changes. Whereas asthma, again, you're going to have x-ray changes during an exacerbation or inflammatory process. And then once the asthma kind of settles and is managed and treated, the chest x-ray goes back to quote unquote normal. What we're going to see as nurses, the COPD patient will have a cough. They will have exertional dyspnea, so they're going to get pooped out from doing minimal activity. They're going to have abnormal lung sounds, wheezes, crackles, sputum production. You're going to see some patients with that barrel chest. That usually is going to occur when you have a flattened diaphragm from that hyperinflation, that long-term hyperinflation. They're going to use accessory muscles to breathe, orthopnea, and a prolonged expiratory phase. You're also probably going to see abnormal arterial blood gases showing an acidosis. Patients with COPD, if you remember, tend to have increased CO2. So you shouldn't, you should try to manage them conservatively because you don't want to decrease their CO2 to normal per se, because that could suppress their respiratory drive. So what we're going to do as nurses is we're going to do good vital sign monitoring, watch their pulse oximetry, administer oxygen, supplemental oxygen conservatively based on their ABGs. We could do respiratory treatments, prescribed medication, CPT, really good breathing techniques like pursed-lipped breathing, if you remember that. That's going to help the patient expel some extra CO2 or as much CO2 as possible. We want to assess their sputum, provide high-calorie, small meals with high protein as well, and we want to encourage fluids because that's going to help decrease or thin out their sputum secretions. Next slide. This is the picture of a hyperinflation of the lungs that you see there on the right. And this occurs over time with patients with COPD. The diaphragm actually flattens because the lungs have become and have stayed hyperinflated. This is how you get that barrel-shaped chest because the patient has had to compensate for their lung changes for so long. So you actually have that AP diameter like 2 to 2 instead of 2 to 1, like normal. Next slide. Clubbing of the fingernails. This is not something that you do in preparation to go to a nightclub here in Las Vegas. This is actually a result of chronic, yeah, I know it's a good one. I got lots of dad jokes. This is chronic hypoxemia over time or chronic low blood levels. You're going to see clubbing of fingernails for patients with COPD, cystic fibrosis, lung cancer, and some cardiac defects as well that are going to have chronically low oxygen levels, like tetralogy of Fallot. Those are seen as primarily in the pediatric population. Next slide. Diaphragmatic and pursed lip breathing. It'll be important for you guys to review diaphragmatic and pursed lip breathing just so that you are able to kind of picture it and conceptualize it in your mind in case you need to convey this and educate your patient about how to do it. And that way you can express to them the importance of why they need to do diaphragmatic versus pursed lip breathing. Next slide. Breathing positions. Look, this guy on the wall on the left, he's really sad. He's like, I can't even make it to bed. I need to just rest here for a second. So what this illustration is showing is a couple of, I would say, good sitting positions. And they're good for the fact that they're going to open up the patient's lungs. The fact that they are leaned forward and they have their arms either rested on their shoulders or on the table, that's something referred to as tripod positioning. And it just allows for chest expansion for certain patients, like a patient with COPD. You might have them do tripoding to help them kind of open up their lungs and breathe a little bit better. Next slide. Okay, a client with chronic obstructive pulmonary disease is receiving theophylline, and the nurse is monitoring the client for adverse effects of the medication. What signs or symptoms indicate an adverse effect? And this is select all that apply.
This is a question that won't have a poll attached to it, Lisa.
Okay. All right, no problem. I'm going to give you guys just a second to come up with some answers in your mind, and then we'll go over it. Okay, so I think to be able to answer this question, you need to know about the medication. I would say it's more about the medication and the adverse effects of what it is than really about the disease itself. COPD is the reason the patient's getting it, but what are we going to see when the patient actually takes this medication? And so a good strategy that I would use is the whole true or false thing. True or false, tremors are an adverse effect of theophylline, and you go down the list that way. We have to know that theophylline is a CNS stimulant. So if you can identify that, you can probably identify the answers that are kind of like, and when I think of stimulant, I think of something that's going to kind of be aggressive and kind of irritate and increase things that go on in the body. So with that perspective, our answer is tremors, headaches, palpitations, and restlessness. So 1, 2, 3, and 5. Now, the reason why bradycardia is not an answer, because we would have tachycardia. If we think about that whole aggressive stimulant aggravating thing, we would have an increased heart rate. And this is for the visual learners. This is increased heart rate just for you, as opposed to bradycardia, which is more of a depressant side effect or adverse effect. So 1, 2, 3, and 5. Okay, for the hospitalized client, which factor would the nurse determine to be a symptom of pulmonary embolism? Okay, nice. Yes, the answer is 3, abrupt onset of dyspnea and apprehension. Very good. To answer this, you have to know or be able to define what a pulmonary embolism is and what you would anticipate to see in this patient. One of the most common signs of a patient with pulmonary embolism is apprehension, restlessness. They're going to start to have blood-tinged sputum that they would cough up. They're going to have chest pain, a cough, abnormal lung sounds, and changes in their vital signs. However, from that list, it could also be like a million other things. And so that apprehension and restlessness is really important for that patient with pulmonary embolism. Next slide. Okay, so we have a patient with pulmonary embolism, and we are going to insert a filter, which is part of the treatment and management of a patient with a PE. So you have a clot that forms, it breaks off, it travels to the heart, and then it gets lodged in the pulmonary artery, and rut-row, you have an issue. Risk factors of pulmonary embolism usually include a history of DVTs, patients that are immobile or have prolonged immobility, obesity, and heart failure. Those are just to name a few. What the patient will experience, like I said, apprehension, restlessness, blood-tinged sputum from their cough, chest pain, abnormal lung sounds. You can also see jugular vein distension, and they have this, along with that apprehension, that impending sense of doom. So treatment is going to be aimed at alleviating those risk factors that the patient has and inserting a filter. It's like a Swiss cheese umbrella that they put in, and it catches the clots. And it's a surgically placed filter done in cardiac cath lab through a major vessel into the IVC to trap the emboli. And so that's what it kind of looks like there. Next slide. A client underwent a thoracentesis a few hours earlier. Which finding would the nurse report immediately to the healthcare provider? Okay, the majority of you got that one right. Diminished breath sounds on the infected side. Very good. So let's break this one down a little bit. So we want to know what a thoracentesis is, and keep in mind, I think, this one of your post-op complications. What post-op complications can occur from any surgical procedure? Crepitus, number one, is sub-Q air, and you won't necessarily have that from a thoracentesis procedure. Number two, a fever of 99.4 is not actually a fever, so we can eliminate that one. And number four is slight drainage of dark blood from the puncture site. Slight drainage, that could be an expected or anticipated finding, considering they just had something puncture into the lung. And so what we don't want is diminished breath sounds on the affected side, knowing that the thoracentesis is a procedure where they actually punctured the lung for removal of fluid or air from the pleural space. So because that's a very invasive procedure, ensuring that the lung hasn't collapsed or that there's no other major lung implications from the thoracentesis procedure is what we would want to report to the healthcare provider. A good thing to do is prioritize your ABCs for this one. ABCs, airway, breathing, circulation, pain, and patient safety. So we got number 3. Good job. And here is the thoracentesis. So this is the kind of most used position for your patient, so that you have good lung and rib expansion so that the provider can go in between the ribs into the pleural space. And this is a procedure to remove air or fluid from the pleural space via needle aspiration. The difference between thoracentesis and a chest tube is where the provider is actually going to enter either with a needle or a drainage system. And so with the chest tube, we actually have a drainage system that remains in place, as opposed to a needle obtaining what it needs to and then it being removed. And the patient's usually positioned upright, head of bed is elevated, and the patient is positioned on the opposite side of the affected side. For the client newly diagnosed with asthma, the nurse reinforces that which medication is most effective for providing quick relief during acute episodes. Okay, we have a good spread, kind of a little bit of everything. All right, let's go through and figure out what we want. So a client has asthma, and which medication we want to know is most effective for providing quick relief. That's going to be really important because an asthmatic is going to have a couple of medications. They're going to have one for quick relief, and they're going to have one for daily maintenance. And so we want quick relief, and that's going to be number 2, a beta agonist via a metered dose inhaler. That is going to, that's going to help kind of expand their lungs and any sort of narrowing, inflammation, or obstruction, and it's going to help the alveoli get good ventilation to occur. So number 2 is your correct answer. Beta agonists stimulate bronchodilation. Next slide. Okay, asthma is an airway inflammation and hyper-responsiveness to a trigger that causes an IgE-mediated response, generally caused by environmental factors, physiologic factors, occupational factors, food, exposure or medication exposure. So remember, going back to COPD, now we're talking about the characteristics of an asthmatic patient, and you're usually going to have an onset of asthma or a diagnosis of asthma before the age of 20, so it's much younger. Symptoms for asthma are going to vary depending upon the trigger that the patient's been exposed to, the compliance, their everyday compliance and regimen, and their other risk factors that they might have. Lung function can be normal in between exacerbations. So when you have an exacerbation, you have abnormal lung sounds. You might have a decrease in oxygen saturation. You can see those X-ray changes, but once it's managed appropriately, that lung function returns back to its baseline. What the patient will experience with an asthmatic episode, breathlessness, wheezing, sometimes audible wheezing, a chest tightness, coughing, that's just like the narrowing. So a coughing can occur and is often treated with a bronchodilator. They're going to use accessory muscles, and you're going to see vital sign changes often in their heart rate and their pulse oximetry reading. What we can do as nurses is we can position them. High Fowler's is going to be important for these patients, or that tripod position. Here we can administer oxygen as ordered. Usually it's titrate to keep SATs greater than 95%, 92%, whatever the provider puts in. They're going to get bronchodilators and anti-inflammatories, and we want to continually reassess their respiratory system for improvement or deterioration. The deterioration is going to be status asthmaticus, which is very life-threatening because it's refractory to treatment, meaning it doesn't like what we're doing, and there's no improvement despite treatment and management. Next slide. What intervention does the nurse identify as the priority for the client with ineffective airway clearance related to pneumonia? Okay, nice. The majority of you got it right. Number 4, teaching coughing and deep breathing techniques and maintaining hydration. Because if we go back to what's the priority for ineffective airway clearance, you have to kind of think what that means to you is that your patient can't effectively clear their airway. And so what is really going to help with that is, or most effective, what should be the priority to address that is number 4. Providing supplemental oxygen will help, but it's not going to be the most effective, so it shouldn't be the priority. Head of the bed elevated, again, a really useful tool that we would do. And number 3, prepare the client for possible insertion of a trach tube. That seems a little excessive, so we can throw that one out. So number 4 is going to be the best, so that should be our priority. Okay, this is an illustration of pneumonia. Pneumonia is an infection of the interstitial space, the alveoli, or the bronchioles. The inflammation from the infection can cause lung stiffness, making deep breathing very difficult and painful. It also can decrease lung compliance or the ability of the lungs to stretch, which can cause hypoxemia for our patients. Pneumonia can be community acquired or hospital acquired. If you have a hospital acquired infection or pneumonia, that's a hospital acquired infection, and that's a big no-no. You can also have ventilator acquired pneumonia, where the patient's been on a ventilator, mechanically ventilated, and they have received pneumonia from poor management or prolonged intubation sometimes. Signs and symptoms our patient would experience is they probably have a fever. They're going to have some chest pain or pleuritic pain, abnormal lung sounds. They're going to have sputum production or sputum changes that occur, and they're going to use their accessory muscles to kind of help them breathe. What we do as the nurse is we want to monitor their oxygen status, monitor their vital signs, listen to their lung sounds, and watch their work of breathing. Teaching turn-cop deep breathe, the use of incentive spirometry is really important. And to do that effectively, we want to make sure we have adequate positioning. We want to assess their sputum if they have it, encourage a high calorie, high protein diet, and encourage fluids amongst antibiotic or medication therapy. This, if you guys remember, this is Jose Sanchez, your level 1 simulation. We did all of those things in that simulation. So those are going to be your gold standard treatments for pneumonia. A nurse is preparing to administer albuterol to a client. The nurse should monitor for which before and during therapy. Nice. Okay, the majority of you got that one right. It's number 1, respiratory distress. Very good. So albuterol, we have to be able to identify as something that relaxes the smooth muscle of the airway, causing bronchodilation. And so that is going to be your most appropriate answer. Next slide. A nurse has a prescription to administer, oh man, metaproterenol, yeah, sulfate, and oh man, beclomethasone, 2 puffs each by metered dose inhaler. How should the nurse administer the medications? Okay, so number 1 and number 2 were very popular. Trying to figure out which one to give first and which one should be given second. So let's talk about number 1 and number 2. So the answer is number 1. We want to do a bronchodilator first and then an anti-inflammatory. Try to pull out for medication questions, a prefix or an affix to help you identify what the use is. And I know that you guys identified what the use is just based on like the context of the question. And so then you have to kind of figure out how you're going to give them. So we're going to give them metaproterenol first because that's bronchodilator, and then we're going to follow up with the steroid for anti-inflammatory purposes. So number 1 is our correct answer. Nice job. Next, okay, there we go. I was like, that one looked like the same question. And I apologize for my slaughtering of these words. Whoever made up these names should be punished. Anyway, the nurse has a prescription to give a client salmeterol, 2 puffs, and beclomethasone, 2 puffs by meter dose inhaler. The nurse should administer the medications in which way? Okay, so 97% of you were paying attention to the last question, because this is literally the same sort of question asking you the same thing. How are you going to give this medication? And so salmeterol is different than the one noted before, but the beclomethasone is still the anti-inflammatory. So that's going to come second after we provide the salmeterol, which is going to be the bronchodilator. So number 2 was your answer. Okay, a client has a prescription to take guaifenesin every 4 hours as needed. The nurse determines that the client understands the most effective use of this medication if the client states to take which action. Okay, number 2, that's a correct. That's a correct. Very good. Take the tablet with a full glass of water. Guaifenesin is an expectorant, and if you know that, then you also know that the patient's probably receiving guaifenesin because they have sputum, thick sputum. And so the best thing to do with that is to take it with a glass of water or to encourage fluids in your patients, because that's going to help liquefy your patient's secretions so that the expectorant can do its job and get it out. Next question. A client has been taking isoniazid for a month and a half. The client complains to a nurse about numbness, paresthesias, and tingling in the extremities. The nurse interprets that the client is experiencing which problem? Okay, yeah, this one was tricky. So many slides ago, we talked about this medication and its treatment for tuberculosis. And what I mentioned before is that it can cause hepatotoxicity. So we want to have a good baseline of our liver enzymes. But what this medication also does, it can be neurotoxic. And so our answer is going to be 2, peripheral neuritis, based on the information that we have from this question: numbness, paresthesias, and tingling of the extremities. And so that's going to be a peripheral disease or a toxicity that's going to occur. So number 2 was correct. A client is to begin a 6-month course of therapy with isoniazid. The nurse should plan to teach the client to take which action? %94% got number 2 right, which is the correct answer. Nice job. So again, the same medication, if we use our knowledge of hepatotoxicity to kind of use that, with the scope of looking at our answer options, we can come across report yellow eyes or skin immediately. Hepatotoxicity could make your patient have jaundice or the yellowing of the skin. Your patient needs to take a vitamin B6 supplement with this medication because they can have a deficiency. And generally with this medication, you also avoid tyramine containing foods, anything that's cured, smoked, or processed. And so we could eliminate number 3 and number 4 from those 2 pieces of information. And if you have any sort of disease process, alcohol is never a good idea for consumption. Okay, cardiovascular. Any questions about lungs, respiratory system that we went over? Nada. Okay, you don't have to ask right away. You can think about it some more, but we're going to move on to cardiovascular. The nurse notes that an infant with congenital heart disease has clubbing of the fingers. The nurse understands that this finding is caused by which problem? Oh, nice. Out the gate, 100% poor oxygenation. Outstanding response, very good. Number 2 is our correct answer. When we have congenital heart disease, it's important to pull that out of the question because then you're thinking congenital, this baby is dealing with it for a long time, even in utero. And the fact that they have clubbing of the fingers is also going to point you to a chronic condition. And that will result from poor oxygenation because the heart is responsible for the pumping and the oxygenating of our blood. The mother of an infant diagnosed with tetralogy of Fallot rings the call bell because the infant suddenly developed difficulty breathing. Upon entering the room, the nurse notes the infant is having a hypercyanotic episode. What is the initial action by the nurse?
While they're answering that, Nick posed a question in the chat.
Oh, yeah. Oh, I see it now. That's a great question, Nick. I'll answer that in just a second. Okay. The correct answer is 3, noted by 97% of you. Place the infant in the knee to chest position. If you recall your pediatric knowledge from Dr. Leland, I know she talks about tetralogy of Fallot. Tetra means 4. And so there are 4 cardiac defects that occur with tetralogy of Fallot. And hypercyanotic, if we want to define that, means that you're blue, you're mega blue, you're increased blue. And so you're having an episode where there's no oxygenation that's occurring. And so this is usually an acute spell that these tetralogy of Fallot patients have, often called a TET spell. And so oxygen is required, oxygen that's required exceeds the blood supply. And so squatting or providing a knee to chest position is a compensatory mechanism to facilitate an increase of blood flow to the heart for oxygenation. And so we want to do number 3, place the infant in a knee to chest position. And if they're older, you're going to see it becomes kind of routine for them to squat when they feel these TET spells come on, which it's pretty impressive that it's almost natural for them. However, you should never have a toddler that still has unrepaired tetralogy of Fallot. they should undergo some surgeries to correct it and fix it. To answer Nick's question, he posed a question, can clubbing be reversible? And I'm going to go ahead and say no, it can't, because you're dealing with chronic levels of low oxygen in the blood. And so if a patient has a congenital heart disease, they're usually dealing with some abnormalities of the heart. Like in my experience, it's never been known for a baby to be born with a heart disease and it be corrected and they're kind of fixed. They're always going to have an increased risk of infection. They might always have some sort of shunting issues where you have a mix of oxygenated and unoxygenated blood. They might have lower than normal oxygen levels. So from this, they're always going to have a low baseline level of hypoxemia in most cases. And so no, I don't believe the clubbing is reversible in my experience. You're welcome. Thank you. The nurse is caring for an infant with congenital heart disease, which, if noted in the infant, would alert the nurse of the development of congestive heart failure. Okay, we got a good little mix. No one chose number 2, so that's a good thing because number 2 is a normal response, not something that we would need to be alerted to. We want babies to have a strong sucking reflex, so it's good we can eliminate that one. What we do want to choose is number 3, the diaphoresis during feeding. Any babies that have a congenital heart disease or they're born with a heart defect, we need to be really cognizant that eating for them, is not inherent or natural. It surprised me as a pediatric nurse how many babies struggle with feeding. It's hard work. Now you throw in a congenital or chronic disease, it can become even harder because feeding these babies is exercise or activity for them. And so with a baby with chronic heart disease, we always time the feedings and we don't let them feed longer than 20 minutes generally, because then you're having more calorie expenditure than calorie gain. And so sweating could indicate several intolerances, that they're working too hard, that they're having too much fluid, could be a sign of heart failure, or even could be indications of some other things. And so number 3, diaphoresis during feeding was our correct response. Nice job with that one. The nurse is monitoring an infant diagnosed with congestive heart failure for fluid overload. The nurse should assess the urine output using which best method? Nice. Okay, so if we break down, we have a little bit of an answer spread for 2 of them, number 1 and number 3. So if we look back at the question, we're talking about a patient with congestive heart failure. And so we want to be on the lookout for fluid overload. That's going to be really important for that patient because they're already at risk for decreased cardiac workload and the ability for the heart to actually pump effectively. And so one of the best things that we do is we monitor Intake and output. Yes, we do. Our correct answer, however, is number 1, because we're looking at an infant and we're looking at fluid overload. So what we want to do is continually assess their urine output. Best method is to weigh the diapers. So weighing the diapers is very specific to answer the question of what the question is asking us. So weighing the diapers, number 1. Oh, we moved on. Get it together. Before discharge, the nurse has reinforced instructions regarding home care with the mother of a child who underwent heart surgery. Which statement, if made by the mother, indicates a need for further education? Okay, number 3 was the answer of choice. Visitors are not allowed for at least 1 month. So what we're looking for, and Dr. Silvestri said it earlier, with these negative event query questions, you have to look for the incorrect answer to be your correct answer. So make sure that when you're reading questions like this, you're really identifying that question right before the question mark. Need for further education, need for further teaching. That's going to tell you I have to flip my mind switch to look for something wrong. And the wrong answer is visitors are not allowed for at least 1 month. We don't need to restrict visitors for that long. It's not something that requires to be a part of the instructions for home care for this mother. Definitely something along the lines of make sure whoever comes over is not sick, wash their hands, that sort of thing, but you don't need to have nobody come over for a month for this patient. Next question. The nurse is collecting data on a child with a diagnosis of rheumatic fever. Which question should the nurse initially ask the mother of the child? Okay, so the majority of you chose number 4, which is this box. Has the child complained of a sore throat within the last few months? Rheumatic fever is an inflammatory autoimmune sort of disease process that can affect your heart, joints, skin, your CNS, and some blood vessels. And so to be able to answer this question, you really need to be able to identify and define what rheumatic fever is and what you would see. And so asking that initial question, has your child complained of a sore throat within the last few months? That's a really good thing to start to think of, because sore throats can manifest about 2 to 6 weeks before the rheumatic fever diagnosis, before the patient can become symptomatic. And so 2 to 6 weeks prior, if you have some sort of viral process going on that's left untreated, for example, group A, beta strep throat, that's what number 4 is getting at. And that's a precursor to having rheumatic fever. After all my jumbled words, I'm sorry. Was that clear for everybody? Because I kind of was all over there for a second. Just want to make sure that I was clear. Okay, thank you, Salma. 1 response is good enough for me. Next question. When reinforcing information about an upcoming cardiac catheterization with a client, the nurse includes which key point about the procedure? Okay, the majority of you chose number 4. Occasional sensations such as warm flushing, urge to cough, palpitations may be felt during the test. So what we're really answering is what the cardiac catheterization procedure is going to be like. So if you're not quite sure what a cardiac cath is or what the patient should anticipate, kind of reviewing that and reading over is going to be really important, because that's what you have to focus your answer on, is what the procedure is all about. And so we can eliminate number 2, it's necessary to lie quietly on a hard x-ray table for about 4 hours. That's kind of like non-therapeutic, kind of saying, you know, you're going to hate it, but oh well. So I would eliminate number 2, and number 4 is our correct answer. If you can identify that when the catheter is inserted into a major vessel of the patient's heart, then you are able to prioritize number 4 with the anticipation that there might be some injecting of dye going on, that we are being intrusive into the vessels near the heart. Those are kind of the things that you can anticipate telling your patient they might experience. However, as scary as these all sound, you also have to say what safety things that you as the nurse or the cardiac cath team are going to do to mitigate those things. So that's really important. If you're going to share something scary about a procedure, also say, hey, but we're going to work really hard to not have those happen. We just want you to be able to anticipate some of these feelings and senses that you might experience. Next slide. Okay, so then you got one arm cardiac cath man here. Cardiac catheterization is a procedure that allows for visualization and information obtainment about structures, performance, and function of the heart, including the chambers, valves, and the coronary circulation. Cardiac cath can be used to rule out angina versus MI. It can check for the patency of the arteries and can also be interventional diagnostic for treatment or management or diagnosis of cardiac defects in infants and children. It is an invasive procedure, requires informed consent, and usually a pre-procedure checklist is used to adhere to in preparation, like maintaining NPO status, ensuring that you have appropriate labs or diagnostics before the exam, putting the patient on IV fluids, making sure that you check for allergies, and obtaining baseline vital signs. As this illustration suggests, major vessels are used for access of the cardiac cath, including the femoral and the brachial, and that usually helps them gain access to the superior or inferior vena cava and then to the heart. Post-procedure for cardiac cath, we want to monitor vital signs and the heart rhythm of the patient, because the heart and the vessels have been aggravated by this procedure. It can lead to dysrhythmias. So that's something we want to be on the lookout for. We want to do circulation movement sensation checks, CMS, and we want to really focus on the extremity. So if we went through the femoral vein, we want to make sure that we have appropriate circulation, movement, and sensation of that extremity. We usually maintain a compression dressing to the vessel that was accessed, and we want to assess for signs of bleeding, because we usually use a larger vessel, and you have a large catheter that went in it, you can have substantial bleeding. Usually the patients are maintained on bed rest for up to 12 hours post-procedure, and you want to keep the extremity straight and not elevated because we don't want to promote blood flow or blood return. So we want to keep it flat and straight. Next slide. The nurse is speaking with the client who's been scheduled for an exercise stress test. The nurse reinforces which item about preparation for the procedure. We need some like thinking music, right? Maybe I request that for next semester is some like, I don't know, music in between, some elevator music perhaps. All right, the majority of you chose number 3, put on comfortable rubber-soled shoes such as sneakers. If we look at the question, we see that we're going to be doing an exercise stress test. So from just your experience in general, watching it on movies or TV shows, exercise stress test is usually done by running on a treadmill. So with that in mind, you would look at your answer options with that sort of perspective, or having really known what an exercise stress test is. Put on sweatpants and a heavy sweatshirt. That's Lisa when she goes to the gym, when she's trying to shed some extra calories and pounds. And then I put like this big hefty plastic bag over myself as well. We want the patient actually to be NPO. So we want to avoid eating a small meal before the procedure, especially if they're going to be running on a treadmill, right? They're just going to throw up all over you. And then avoid cigarettes for 30 minutes before the procedure. We definitely want to do that. However, you know, this patient might be smoking anyway. And so our best answer is to put on comfortable rubber-soled shoes, such as sneakers, to help them run most effectively on the treadmill as best as possible. And here he is. Look, he looks like he's having too much fun, and that the doctor with the weird mustache is just like mean mugging him. You're not running right. So an exercise stress test is non-invasive test that can study the heart during activity. And it can be used to evaluate or detect coronary artery disease. It can look for angina or MI, sort of changes in the cardiac rhythm. A stress test can be done in several different ways. Running on a treadmill is one of them, and you have the EKG monitoring. If the patient cannot tolerate running on a treadmill, then they can do an IV stress test. And where the patient is connected to the EKG monitoring, but then we do an IV infusion of a medication that is going to dilate the coronary arteries and stimulate exercise. That's what a non-exercise stress test does. So generally the patient's NPO prior, we need an informed consent. They have to wear comfortable running shoes, and we want to check medications to ensure compatibility, especially if they're getting that IV injection. We want to make sure that it's not going to have a weird effect. And then we want to make sure after the procedure, in both circumstances, that the patient is safe, that they're not experiencing any dizziness, chest pain, heart palpitations, or anything like that. We have a question. I know you can't hear anyone, but I'm sure they're all laughing like I am. Yeah, I imagine they are. I imagine a room just full of laughter. Like we're at a nightclub and it's my own stand-up. Next slide. Half of my rambling and jokes are because I'm nervous. Like, I haven't really talked to you guys or seen you in a while, and now I'm just talking to some black boxes, and it gives me anxiety. So my rambling is nerves. I apologize. Okay, question. The nurse would reinforce which discharge instruction with a client who underwent permanent pacemaker insertion? Okay, interesting. We got a good spread here. So there's a little bit of answers for everything. So let's go through these bad boys and kind of figure it out. The nurse would reinforce which discharge instructions with a client who underwent permanent pacemaker insertion. So pacemakers are usually done because the patient experiences some sort of cardiac dysrhythmia and needs some control over the rhythm, the mechanic portion of the heart, because the electrical system is malfunctioning for whatever reason. So number one, I would eliminate because I don't want to avoid swimming permanently. Permanently is very like forever. It's like one of those answer options. We want to avoid all exercise. Mobility and activity is going to be really important. So we don't want them to stop swimming if that's their activity of choice. So I would eliminate number one. We don't want to ever wear snug clothing over a generator site. I always think of snug clothing as kind of a bad answer option anyway. Kind of like if you're thinking about females with a UTI, wearing tight clothing would be bad and increase their risk for a UTI. You want something that is loose fitting and breathable. So I would eliminate number three as well. Notify agents about the pacemaker after walking through security scanners. You actually want to do that before so that you can go the special route and they can pat you down in public in front of everybody and everybody stares at you and it's weird. So you want to do that as opposed to going through the scanners. So our correct answer is going to be number two, to count a 60-second pulse rate daily. This is going to help you keep track of a pattern of what your heart rate is doing. And so you really want to teach your patient how to do that, have them return demonstrate so they that they know how to count their pulse and to write it down in some sort of journal. That way they always have it to bring to follow-up appointments with them. Next. The nurse has a prescription to administer a dose of nitroglycerin ointment to a client. The nurse should avoid which action in preparing the medication for administration? Okay, beautiful. The majority of you chose number four, which is our correct answer. If you remember, level one, the skills lab, and we used that nitro ointment. It was on a paper, and the provider's order would be 1 inch of nitro ointment applied to patient topically once daily, or Q12 or Q3 hours, Q3 days, or whatever it was. So we do want to use the manufacturer's paper because that is what comes with the ointment to be able to distribute it onto your patient topically. We do want to apply the dose in an even layer. Now, if we look back at the question, this is telling us what we should avoid. We definitely want to do an even layering, not just like pile a big old thick layer of ointment on in one spot. And we always remember we would wash off the previous application. So if it was on the left, we'd wipe it off and we would rotate our site and put it on the right side the next time. What we do want to avoid is using our fingers to spread the ointment because nitro is a vasodilator. And so it happens immediately on contact. So if you're using your fingers to spread the ointment, even though it's meant for your patient, you are also going to participate in that vasodilation and you are not going to feel well. So make sure that you wear gloved hands and that you wash your hands after application. Next. During a code blue, the healthcare provider who is about to defibrillate a client in ventricular fibrillation says in a loud voice, "Clear." The nurse should take which immediate action? Nice, 100%. All of your years of watching Grey's Anatomy, you're probably all too young for that now. Maybe, I mean, I think it's still on. ER, Scrubs, you gotta step away from the bed and ensure all others have done the same, because you don't want to participate in that defibrillation. All right. Now we have some, I can assure you that we watch Grey's, the most ill-informed show, but you gotta love all the drama and all the hot doctors. I have to tell you before we move on, I don't know if you guys remember, I told you, maybe not. I lived in Seattle for a year, which is where my husband's family's from. And I was so excited to move to Seattle because I'm thinking I'm going to work at Seattle Grace Hospital. That place doesn't exist. Nor do any hot doctors like that exist. I've been looking for, 17 years now. I don't see anybody. So, and when there is a hot doctor, all the nurses are like, and harass the poor guy or woman. Anyway, ventricular fibrillation. These are scary. You guys like that one, okay. These are really scary heart rhythms. But heart rhythms, I want to say, are very complicated and complex. So have patience with yourself with this particular topic. It's going to take a while for you to pick up and be able to identify confidently the characteristics of each rhythm. So if you happen to end up working in a cardiac ICU or on a cardiac telemetry unit, you're going to become better equipped and more well-informed about this because you're working with these patient populations more often. Okay, but ventricular fibrillation and ventricular tachycardia are life-threatening rhythms. VFib, as we like to call it, because it's easier to say, it's where the heart beating process is not happening in the right order. And VTAC is where the heart beating process is not happening in the right order and it's occurring too fast. So because of both of those, you don't have adequate blood flow that's able to pump systemically, and you have minimal to no cardiac output. So because these rhythms, VTAC and VFib, are not compatible with life, they're shockable rhythms. We have to treat them. We can't just let them kind of work themselves out. Patients with VFib can be unconscious. They can also have no pulse and no recordable or readable blood pressure that can be measured, and sometimes no heart sounds either. So what we do for these rhythms is, on top of defibrillate them, is we also have CPR, and we follow the ACLS algorithm, Advanced Coronary Life Support algorithm, and we do CAB, compressions, airway, breathing. And we want to also maintain environmental safety of the code team. And that's what we experienced in that last question, is when we actually go to shock or defibrillate the patient, we need to make sure everybody is safe. And so we want to shout all clear and make sure everybody's standing back away from the bed and the patient. A code situation, if you have ever experienced it or witnessed it, has to be a very organized situation. Oftentimes you have looky-loos, so feel free to take it upon yourself to shoo everybody away that doesn't need to be in there, because you have people that are in there with specific jobs. Everybody else can go. They can go and they can see it another time. And so you want to make sure you have your MD, who's usually the code team lead. They're the ones giving the orders. A charge nurse can usually fit in there, or a provider resident. You have a recorder. You have someone that manages the airway, and you have a compressor. Someone's doing compressions, and then you have a runner, and that runner can also be a switcher outer, so that they can take over either bagging the patient or take over compressions. Next slide. The nurse is assisting in the care of a client with known heart disease who suddenly develops dyspnea at rest. The nurse should plan to take which action first to assist the client? Okay, and 97% of you, so almost all of you, that's great, chose number 2, which is to elevate the head of the bed to at least 45 degrees. And really, if we look at it, that's really the only intervention that's going to be helpful. So if your patient has dyspnea, it's kind of a shortness of breath, but an inability to really take in a good deep breath. So they almost become breathless. I don't think it's the best time to start ambulating if they can't even breathe at rest. Monitor oxygen saturation is not going to help correct the dyspnea. Place an oxygen cannula at the bedside for use if needed. That doesn't really help. You're kind of looking at it like, hey, it's not doing anything. So number 2, if we look at it with that sort of perspective, that's the only one that's going to help. Because certainly if someone's short of breath or dyspneic, laying flat is only going to make it worse, not better. So sit them up. Positioning is a free intervention that we always have in our toolbox that helps tremendously. So make sure you use that when it's appropriate. I didn't see this question before, but someone asked me McDreamy or McSteamy, and I think that's important for us to talk about right now. And I would always pick McDreamy because he was also in Sweet Home Alabama, and he was in that one movie with the cartoon princess, and then she turns to life. I don't remember that one, but that was McDreamy is my answer for that one. Enchanted. Thanks, guys. That's a great movie. Break for lunch, 12:30. Okay, thank you. All right, I should hurry up, so no more stories. Oh, wait, go back. No, this is the right one. I apologize. A client with myocardial infarction should reduce intake of saturated fat and cholesterol. The nurse would help the client comply with the diet therapy by selecting which food items from the dietary menu. Okay, 100% out the gate. I think you guys were able to identify that answer 3 was the only food choices that were kind of boring. So boring is healthy. No, I'm just kidding. Those were the ones that showed a reduced saturated fat and low or no cholesterol foods from option number 3. Next question. A client receiving nifedipine for angina complains of feeling listless with generalized weakness and no energy. In order to support the client most effectively, the nurse should understand which about these symptoms. Okay, interesting. So there's something for everybody on here. The majority of you chose number 3. So let's go through this and see if we could figure it out. So nifedipine, we have to identify as a calcium channel blocker, and the use of nifedipine or a calcium channel blocker as an anti-anginal medication. So your patient has angina, they're receiving this medication, but they're having some side effects or symptoms that we don't really know what these are just yet. So listless, generalized weakness, and no energy. So really, to be able to answer this correctly, we have to know about some of the anticipated side effects of this medication. And one of them is number 2, I apologize, are an expected effect of the medication. This medication tends to kind of make you feel like you have no energy. And so that's something that you can educate your patient about when they start receiving this medication to anticipate feeling this. However, if you feel this way, there comes a time when you should be reaching out to your healthcare provider. And so you can provide them with a good, well-rounded education about this medication. So number 2 was our correct answer. Next slide. Locations of a myocardial infarction. You have 4 different pictures here, kind of showing you all different perspectives of the heart. And MI occurs when there's limited or no oxygen available to the heart's tissues. Remember that the heart has its own special system of circulation. And MI usually evolves over time, and it's important for identification of risk factors early, and take note of weird or vague complaints from your patient. Don't just kind of dismiss them. Risk factors for an MI: history of atherosclerosis, coronary artery disease, consistently high cholesterol, obesity, hypertension, smoking, increased levels of stress, and inactivity. Signs and symptoms of an MI can kind of be a lot of different things, and it can also vary depending upon if you're a man or a woman. Chest pain, that's going to help you really distinguish between an MI versus anginal pain. Nausea, vomiting. Some patients are going to describe this pain as crushing, can radiate to the jaw, the back, or the left arm. The patients become diaphoretic and pale, and they have coolness in their extremities because they're not getting good perfusion to their extremities. They can be dyspneic, and they have this sort of fear or an anxiety, that impending doom, almost similar to a pulmonary embolism. They know that something's not going well inside there, and so they actually tell that to you, they verbalize it. Next slide. Electrocardiographic changes in an MI. So an ECG or an EKG, you might see either one, is a diagnostic test that helps determine what type of MI may be occurring in your patient. If you have an ST wave elevation, you might hear a STEMI be called. That's an ST elevation myocardial infarction. Or you can have an abnormal Q wave, which is an N STEMI. And so if you hear those overhead, it's important that you kind of understand. And if you're working in those particular areas, you will start to know sort of the algorithm and the standards of care for dealing with a patient with NSTEMI or a STEMI. So you can have those, or you can have an ischemia. Ischemia is the cardiac tissue injury or death, and that will show a different rhythm when you're looking at an ECG. So when reading an ECG strip, there's several things that you look for. You look for the uniformity of the wave, so PQRST in uniform. You also want to look for the presence of all the waves. PQRST is there with each one. You want to look for a normal rate of 60 to 100. And if you measure those waves, each wave should have a different interval measurement, and that's where people can get out the calipers and all of that stuff. And so that's the part where I was kind of alluding to earlier, is when you're learning about cardiac dysrhythmias, you learn about all those characteristics and what dysrhythmia is going to have what characteristics or which measurement or which drop in the wave. And so it's very complicated and time consuming, tricky to learn, but it's really fun. Next slide. The nurse reviews the history of a client tentatively diagnosed with Raynaud's disease for documentation of which important risk factor for this disorder. Okay, so we have number 1 and number 4. Number 4 was the most popular one. So the nurse reviews a history of client tentatively diagnosed with Raynaud's disease for documentation of which most important risk factor for this disorder. So our answer is actually going to be number 1, which is cigarette smoking. Raynaud's disease is a disease of where vasospasms occur that causes vasoconstriction. So Just because a patient has a history of peripheral vascular disease doesn't necessarily mean they're going to have Raynaud's disease. But if they are smokers, that's going to put that more at risk for that vasospasm, which then can cause the vasoconstriction. So number 1 is going to be our correct answer. Next slide. And you see a picture of it here. So a vasospasm usually occurs in the arteries or the arterioles, and it causes vasoconstriction of the upper and lower extremities. It will usually occur because of cold environmental exposure or increased stress, or outside factors like smoking. What we're going to see is blanching of the extremities and cyanosis. So there's like this mega discoloration. It kind of looks like red, ruddy, blue, and even super pale, kind of like that illustration on the right. You're going to have reddened tissues when the vasospasm is relieved. So all of that blood flow kind of returning. And so the hands look like mega red. And the patient will complain of numbness, tingling, and potentially swelling to that affected body part. What we do as the nurse is we can monitor the pulse of that affected extremity. We want to administer medications like vasodilators. We want to educate why they should avoid smoking, why that's important. We need to educate them on how to dress for cold weather and avoid stress triggers if possible. Next slide. A client hospitalized 3 days ago after multiple trauma is at risk for deep vein thrombosis due to immobility. The nurse plans to routinely monitor this client for which manifestation compatible with DVT. Okay, so the most popular answer chosen was number 1, unilateral edema, which is our correct answer. We want to look at a piece of information from the question, and that this patient is at risk for a DVT due to immobility. And so what we want to do is we want to actually start to look for edema first. You're going to see one extremity sort of swell much bigger than the other, and that's going to then lead to diminished pulses and coolness or pallor of the affected limb. So it's kind of like which comes first, the chicken or the egg. In this case, edema comes first, and then 3 and 4. Venous insufficiency, arterial ulcer, ulcer formation, and gangrene. So venous insufficiency is caused from prolonged venous hypertension, causing stretching that damages the vessels or the valves. And usually what happens is you get edema, venous stasis, ulcers, and cellulitis can occur. Arterial ulcer or peripheral arterial disease is a chronic disorder that can either have partial or total occlusion, and that's usually caused by atherosclerosis. Both can lead to an ulcer formation or gangrenous infection. Interventions for these would include work to increase venous return to the affected extremity. Okay, so we can do things like compression stockings, avoid prolonged sitting or standing. We want to instruct the patient not to cross their legs. We can elevate their legs to get that venous return. And interventions for treatment, we can do wound care if they have an ulcer or gangrenous infection. And we want to, of course, do medication or antibiotic therapy. Next. Heparin sodium by subcutaneous injection is prescribed for a client. When administering the medication, the nurse should take which action? Okay, so the majority of you chose number 4, which is our correct answer. This goes back to level 1 knowledge when we learned about the sizes of needles and gauges that we need to use. So if we know that subcutaneous is going into the subcu tissue and we don't need an ultra long needle, we don't need anything more than an inch, so an inch or less. So 3 and 4 could be potentials, but then we have to also remember the gauge or the gauge of the needle, excuse me. And so we want to use the smaller end of the needle sizes. And so the larger the number, the larger, the smaller the size. And so 25 to 27 gauge plus a short needle, because we're going into fat, would give us our appropriate answer of number 4. Next slide. The nurse is caring for a client being discharged to home with a prescription for furosemide. Which client statement indicates the need for further reinforcement of instructions? Okay, so the majority of you chose number 4, need to avoid foods such as bananas and cantaloupes. Again, which client statement indicates the need for further reinforcement of instructions? That is us. We need to identify a wrong answer to be our right answer. And so there's really no need to avoid foods that are rich in potassium, which is, I think, why that one was chosen. But it's not necessary. So we can actually choose that one as something that we would need to reinforce. Next slide. A hypertensive client taking metoprolol is having the dosage decreased. The client asks the nurse why this should be done over a period of 1 to 2 weeks. The nurse includes in a response that abrupt withdrawal could have which effect? Okay, so if we want to identify what this medication is, first to help us, we use part of the word metoprolol and an LOL as a beta blocker. And so we know that's used for the management of hypertension, which we can maybe assume from the context of the question, but I never like to assume. So if we're using this medication to help treat and manage a patient's hypertension, we shouldn't just stop it immediately, because that could actually cause number 3, rebound hypertension. So the hypertension comes back and it comes back full force and sometimes even higher. And it's hard to manage it appropriately if we just all of a sudden stop a medication. So everything should be tapered according to a provider's order. So number 3 is our correct answer. A client diagnosed with congestive heart failure is being treated with digoxin and furosemide. Which finding on data collection would lead the nurse to suspect that the client is hypokalemic? Good. So this question is really asking you about signs and symptoms of hypokalemia. It's not actually talking about anything with congestive heart failure. And that's my takeaway is what do I need to know or what should I know about hypokalemia? You can define a couple of things if that helps you kind of going through each step. What's digoxin, what's furosemide? But hypokalemia is that low potassium level. And so what you're going to see is muscle weakness and leg cramps. In associated with digoxin, however, hypokalemia is really important to know, identify, and treat in patients because if they're on digoxin and hypokalemic, that increases their risk for toxicity. So that little piece of information is important, kind of putting those two together. Number 4 was our correct answer. Nice job. A nurse is caring for a client with a history of heart failure who's receiving diltiazem for hypertension. The nurse should check the client for which adverse effect?
Sorry, it's like I'm out of order again. Give me a second. Let me see if I can find the question.
Okay, no problem.
Okay, I guess I don't have this question. I apologize.
Okay.
I was putting it together.
Yeah, no problem. Okay, so adverse effect to us is something that we don't want to happen versus a side effect is an anticipatory symptom occurring. So adverse, what don't we want to happen if this patient's receiving a medication for hypertension? So hopefully you were able to identify that for a patient with heart failure, number 4 would be things that you don't want to happen. You don't want them to have bradycardia because with heart failure, the heart is already kind of fat and flabby and it doesn't really pump effectively. So you don't want them necessarily to have a slow heart rate. You want them to have like a quote unquote normal heart rate. You don't want them to have weight gain or peripheral edema because that's also showing you that they're kind of not eliminating extra fluids and that could put undue stress on the heart. So our correct answer was number 4. A client with a diagnosis of heart failure is seen in the clinic. The client is being treated with a variety of medications, including digoxin and furosemide. Which assessment finding would lead the nurse to suspect that the client is hypokalemic? Hopefully you're paying attention before. Oh, see, I knew I liked you guys. 100% chose number 4. Excellent. Those are going to be the kind of the assessment findings that we would see and anticipate a low potassium level. Diarrhea and colic, 1 and 3, is really hyperkalemic. GI motility is hypo, and then twitching would be calcium. But the fact that we're on that digoxin again and low potassium, we really want to identify that partnership and seek to correct whatever symptoms our patient is having of hypokalemia so that we don't have an increased risk of toxicity. Number 4, nice job. We're almost done. A couple more slides. A client will begin drug therapy with warfarin sodium. The nurse expects the healthcare provider to prescribe monitoring of which laboratory test to evaluate the medication's therapeutic effect.
I apologize. It looks like I didn't include the question, but I got the answers right on this slide. So I guess you're allowed to laugh at me for that one.
Okay, no sweat. Okay, the majority of you chose number 3, which is the correct answer, an INR or International Normalized Ratio. That is the lab that is used to assess the coagulation status for therapeutic interventions, including medication management. And so it's really important to kind of know what each one of these things do. A platelet count tells us our patient's coagulability. Can they coagulate? And our activated partial thromboplastin time, PTT, assesses for coagulation disorders. And so, and then the red blood cells is just the amount of red blood cells we have distributed in the blood. Doesn't really have anything to do with our per se coagulation, specifically with this medication. So our correct answer is number 3. Nice job. Which is the therapeutic serum level for digoxin? Nice job. If you don't know, now you know. The correct answer is number 3, 0.5 to 2. That's the therapeutic level for dig. What we need to do when our patient is on digoxin, so digoxin is a good medication, but we use others because dig has a very small therapeutic window. And so your patient has to stay in that. Otherwise, it's subtherapeutic or it's toxic, and that's not good. When our patient's receiving digoxin, we have to listen and count the apical heart rate for 1 full minute. We're not feeling the radial pulse. We have our stethoscope to the apical site. We want to assess for signs of dig toxicity that can include GI or visual disturbances. And we want to ensure we are monitoring that potassium level to ensure it's not low, because that's going to precipitate toxicity. So use diuretics with caution. Warfarin sodium is prescribed for the client. The nurse expects that the healthcare provider will prescribe which laboratory test to monitor for a therapeutic effect of the medication. I know you guys are all looking for INR right now. Where is it? We just talked about it. It's not here. What do we do? Good. Replace your INR with PT. So your prothrombin time. Both of those are going to be able to assess for the therapeutic levels of medication. And so PT is it. Yep. Do I have notes here? Vitamin K, I do. Vitamin K is the antidote for warfarin. If you need to give it. 9.6 to 11.8 is the normal range. And therapeutic is 1.5 to 2 times the amount up to. INR normal is 1.3 to 2, or if a patient's on Coumadin, it can be 2 to 3. If an INR is low for the medication, the dose will be increased. If the INR is high, the dose can be decreased. And if you don't have an INR, you look for the PT. Next. A nurse is caring for a client who's taking propranolol. Which data would indicate an adverse effect associated with this medication? Hey, I actually didn't see, Dr. Silvestri, maybe you can chime in on this one because I actually didn't have notes on this one at all. So the correct answer put out there was number 2, and we can go through this and see if we could figure it out. The nurse is caring for clients taking propranolol, which data would indicate an adverse effect associated with this medication. And so as a beta blocker, we're looking for adverse effect, which is something that we don't want. And knowing what a beta blocker does, we can help to eliminate some of this stuff. So number 4 would be normal. Number 3 would be, normal, the correction of the blood pressure. And number 2, you definitely don't want to hear audible expiratory wheezes, because then we can also try to prioritize our ABCs for this one. And so that would certainly be a bigger priority than number 1. So number 2 is our correct answer.
Yeah, and I'm happy to add to that too. That was a really good strategy, I feel like, to get to the right answer. And so with beta blockers, with this particular beta blocker, this one is used more often for like social anxiety types of symptoms versus as an antihypertensive like some of the others are, or for treatment of heart failure like some of the others are more commonly used for that, like carvedilol or metoprolol. But propranolol, you'll see that used. It's considered one of the least potent beta adrenergic blockers, and so it's used for social anxiety most often. The reason why the development of audible expiratory wheezes would be a concern and would therefore indicate an adverse effect is because you remember with your beta receptors, you have those both in the heart and in the lungs. And with your beta blockers, you have some that are cardioselective and then some that are non-cardioselective. And so the ones that are cardioselective are more targeted to the heart and don't affect as much the receptors that are also in the lungs. So you have receptors both in the heart and in the lungs. But for some of them, they're non-cardioselective, as is the case here. And so if you develop audible expiratory wheezes, it could mean that those beta receptors in the lungs are being affected by the propranolol, and therefore it would be an adverse effect. So if you can try to remember that beta blockers can have effects both on the heart and on the lungs, and that expiratory wheezes in particular, as Lisa said, if they're audible expiratory wheezes, that means that you have some level of airway restriction. We usually see that manifested expiratory versus inspiratory. If you think of somebody who has asthma, for example, it's usually expiratory wheezes that you're going to hear and not so much the inspiratory wheezes, and that is a manifestation of their airway constricting, bronchoconstriction. And when it's audible, that means you don't need to hear it with a stethoscope, like you can just hear it without a stethoscope. That option in and of itself would kind of heighten my attention to it, because it's like, okay, that's not good. So if you didn't have that knowledge base to help you there, just pay attention to options like that are kind of red flag options. And then if you're being asked about an adverse effect, then on that basis alone, I would consider that option.
Beautiful. Thank you. Nick, you have a question?
Yeah, sorry, just really quick. It's just more just so I can kind of keep it in mind when it comes to like a blood pressure or your resting heart rate dropping. How low can it go within the normal range where it would be kind of concerning, like it was too much of a drop?
For blood pressure, it's usually 20 millimeters of mercury or more systolic and greater than 10 diastolic. That's pretty substantial. And then for heart rate, if you're dealing with 88 to 72 beats, that's not really substantial. I would say it's more of the drop in conjunction with feelings of symptomatic things that your client is complaining of. So if they have a substantial, not a substantial drop, they have a drop from 88 to 72, but they don't feel so good, or they feel dizzy or feel shaky, that would be more something I would be in tune to, rather than the decrease, as long as it's kind of within normal limits.
Yeah, I think that, and I loved, Lisa, how you pulled in that about, you're thinking about both the drop and the amount that it goes down, but then also the symptoms. And then also take into consideration this medication here being a beta blocker. We're expecting that the heart rate will go down to some extent. And we just want to make sure, A, that it's not too significant of a drop. 72, it's still within normal range. But then also, as Lisa said, maybe 88 to 72 would be a concern if they're complaining of dizziness, lightheadedness, and then they'd be at risk for falling. And so it's thinking about it from kind of multiple perspectives and getting as much information as you can.
Thank you. Did that answer it, Nick? Yes, you got it. All right, next slide. I think this might be the last one, maybe. Yes. After assessing heart rate and blood pressure, the nurse administers nitroglycerin 0.4 milligrams sublingually to a client hospitalized with cardiac disease who reports substernal chest pain. After 5 minutes, the client states, "My chest still hurts." What action should the nurse take at this time? Select all that apply.
So this is another one that doesn't have a poll attached to it because it's a select all.
Oh, so select all. Okay. So we can answer this as we go through. True or false, if the patient's complaining of their chest still hurting after 5 minutes of receiving nitro, should we call a code blue? You guys can answer. True or false? We'll say false. Okay. True or false, call respiratory therapy for continual chest pain. I'd say false. True or false, assess the client's pain level. If they're still complaining of pain, you got to reevaluate that pain level. Maybe it's not a 10 out of 10 like it was, but maybe now it's a 7 out of 10. So we want to do number 3, contact the healthcare provider. Usually with nitroglycerin, that's part of the order, is that you could administer this medication and then you can repeat a dose up to 3 times with 5-minute intervals. So it's not necessarily time to contact the healthcare provider yet. Recheck the client's blood pressure. We can certainly do that because that's an intervention that might tell us a potential adverse effect from the nitro or from the anginal pain. And so we would include number 5 and then administer a second nitro 0.4 milligrams sublingually. Yes, I said that usually you can repeat it up to 3 times with 5-minute intervals. So we have 3, 5, and 6 as our correct answers. Any questions? That's French for questions. Questions.
Any questions, guys?
Denise says baguette. Come on. You're funny.
They're for lunch probably. Lisa, thank you so much. That was awesome.
Thank you.
Appreciate it. It's a lot of effort. I really do.
I hope you guys survived it. I know that these are long days, but they're so incredibly important. So I'm glad that you guys are here and engaging as much as you can. Thanks for having me.
Yeah, absolutely. Thank you. And I agree, jam-packed days, especially today because it's Med-Surg Day, but one of the more important ones. So thank you for livening it up for us too. That was great. And hopefully, fingers crossed, you'll do it next time around.
Yeah, you betcha. Count me in. Hey, and I'll see you guys in a couple weeks for pinning and graduation. Whoa.
Yeah, I know.
So
right
exciting.
around the corner.
Oh, wait, no, I'll see you on Monday for the poster fair.
Yeah, I thought that I saw your name. I'll be sending stuff out. They got to get me their posters. Get me your posters, guys. I know that you're busy and stuff right now, but like tonight, if you can edit those posters and get them back to me, I got to compile them and get all the info out to the judges and everybody. So thanks for that reminder, Lisa.
You're welcome.
So, all right, well, so why don't we take lunch until 1:15? We are going to go into neuro and musculoskeletal this afternoon, and we are actually going to bump our safe, effective care environment, which is really like the foundational fundamentals content, to tomorrow. It's kind of a nice way to actually end the review anyway. So Devin, would you mind putting the link in for, oh, there you go. Or he sent it to me. Sorry, Devin, I think it was direct message. I will take it, but if you could post it for everybody too, that would be good. There it is. Thank you guys. So enjoy your lunch. I'll see you back at 1:15 and we will wrap up our day. Enjoy your lunch. Thank you. Thanks, Lisa.
You're welcome. Bye, darling.
Bye-bye.